When an endocrine tumor is discovered on a scan, it often looks like an isolated mass, but treating it as a localized problem is a dangerous oversight. That single glowing nodule is frequently a localized alarm, sending signals to hidden nodes across a system-wide network. Multiple endocrine neoplasia, or MEN syndromes, operate within a rigid genetic architecture. A single mutation forces specific glands to fail in predictable, system-wide clusters. Carcinoid syndrome offers a contrasting framework. While MEN is dictated by genetics, the systemic effects of a carcinoid tumor are governed by fluid dynamics. Its impact depends entirely on anatomical vascular routing and blood flow. This creates a significant challenge for clinicians. Symptoms like sudden flushing, rapid heart palpitations, or severe ulcers overlap constantly. Any of these presentations could stem from dozens of highly localized or broadly systemic sources. Memorizing disjointed lists of symptoms is an inefficient way to solve this. Instead, clinicians must build a spatial, physiological map of the endocrine system. Building this map requires two specific sets of data. We need to know exactly which glands group together genetically, and we need to trace the specific venous pathways that carry the hormones they secrete. Mastering complex endocrine pathology requires working backward. You take the clinical presentation and trace the symptoms upstream, moving through biochemical, vascular checkpoints, and genetic phenotypes to find the origin. Removing a visible tumor without understanding the syndromic network it belongs to guarantees one outcome. You will miss the hidden parallel pathologies that ultimately kill the patient. MEN1 is defined by a strict glandular axis, easily recalled as the 3 Ps. The highest point is the pituitary gland. The central point is the parathyroid, causing spikes in serum calcium. The lowest point is the pancreas, completing the triad. Within the pancreas, the most common manifestation is a gastrinoma, a tumor that recklessly secretes the hormone gastrin. Excess gastrin drives extreme acid production, resulting in Zollinger-Ellison syndrome. The defining clinical signs are severe jejunal ulcers and a thickening of the gastric folds. These 3 nodes rarely fail at the exact same time. The timeline of presentation is staggered, meaning a patient might present with a stubborn ulcer years before a pituitary issue arises. Finding hypercalcemia or a jejunal ulcer in a young patient is a mandate. Clinicians must immediately screen the remaining 2 pillars of the P-axis. This Venn diagram maps the MEN2 umbrella. Both type A and B share a lethal baseline of 2 guaranteed components. The first is medullary thyroid cancer, an aggressive malignancy with a near 100% incidence rate in MEN2 patients. The second shared component is a pheochromocytoma, a volatile, catecholamine-secreting tumor sitting directly on the adrenal gland. The pathway splits based on the third gland involved. MEN2A branches left, keeping the thyroid and adrenal tumors, but adding the parathyroid to the cluster. Patients develop an adrenal pheochromocytoma, aggressive thyroid cancer, and a lot of calcium from parathyroid. MEN2B branches right. It completely drops the parathyroid involvement, swapping it out for severe physical and visible phenotypes. Patients with MEN2B typically present with a marfanoid body habitus, characterized by exceptionally long limbs, hypermobile joints, and a tall, slender frame. They also develop mucosal neuromas, small bumps on the lips and tongue, along with intestinal ganglioneuromas. The mnemonic here is that 2B wants to be a gangster, linking type B directly to the ganglioneuromas. The genetic mutation manifests as a specific physical form. Identifying a patient's skeletal structure or mucosal bumps redirects the clinical pathway, differentiating 2B from 2A. These tumors operate under a physiological paradox. Primary tumors are common in the GI tract, yet the syndrome occurs in only 10% of cases. Look at this vascular map of the GI tract. The tumor secretes serotonin into the local bloodstream. Because of anatomical routing, all venous blood from the GI tract drains directly into the portal vein. The liver intercepts it. Through hepatic first-pass metabolism, a healthy liver acts as an absolute firewall, neutralizing the serotonin before it can reach the rest of the body. This creates a hard anatomical rule. As long as the primary tumor remains isolated in the GI tract, systemic symptoms like flushing are biologically impossible. The syndrome activates when the tumor metastasizes to the liver. A mass on the hepatic surface secretes serotonin outward, bypassing the firewall. It dumps directly into the inferior vena cava. Containment is breached, and the hormone achieves total systemic circulation. The immediate clinical manifestations of this systemic flood are episodic, intense skin flushing and severe secretory diarrhea. But the long-term threat is structural. The unfiltered serotonin is carried straight into the right side of the heart. Chronic exposure mechanically degrades the valves. This damage classically causes tricuspid regurgitation, where the valve fails to seal, forcing blood backward into the right atrium. The left side of the heart is spared because the lungs act as a secondary firewall. Pulmonary tissue metabolizes the remaining serotonin before the blood crosses over to the left atrium. The manifestation of the syndrome depends entirely on the precise anatomical moment the hepatic firewall is breached. This diagnostic dashboard shows how knowing the exact biochemical pathways dictates our lab work. For a carcinoid workup, attempting to measure raw serotonin in the blood is practically useless because the liver and lungs metabolize it too quickly. Instead, clinicians order a urine test for 5-HIAA. This acid is the stable, measurable footprint of metabolized serotonin. To locate the hidden tumor, the nuclear medicine test of choice is the octreoscan, utilizing radio-labeled indium-111 to bind to the tumor-specific surface receptors. On the MEN2 side of the dashboard, the priority is neutralizing the adrenal threat of a pheochromocytoma. If a patient presents with elevated calcitonin, indicating medullary thyroid cancer, they must be screened for a pheochromocytoma before any surgical intervention begins. Operating on the thyroid while an adrenal tumor sits unmedicated can trigger a massive release of catecholamines, causing a fatal hypertensive crisis during surgery. Endocrine neoplasia syndromes test a clinician's physiological logic. True clinical mastery comes from looking past the isolated mass and visualizing the invisible vascular and genetic threads that dictate the disease.